our next speaker, Dr. Zosia Piotrowska. She's going to give us her take on the role of targeted therapies in earlier stage disease. So Dr. Piotrowska is a thoracic oncologist from Massachusetts General Cancer Center and Harvard Medical School. So I will turn it over now to Zosia. Dr. Piotrowska.
Great. Thank you. Let me share my screen now. So thank you. It's really a pleasure to be here. My name is Zosia Piotrowska, and like Ben said, I'm a thoracic oncologist at MGH here in Boston. And I have I think really interesting topic of talking about genotype-directed therapies or targeted therapies in earlier stage disease. These are just briefly my disclosures. And so I wanted to start by first kind of defining the nomenclature, kind of talking about some of these terms that we throw around and explaining them a bit more. First, very, very broadly, what do we mean by early stage disease? And I think, when we talk about early stage disease, we kind of lump together all non-metastatic disease. And I've shown some examples here, all the way ranging from stage 1 lung cancers. And this is an example of a patient with a tumor just in their lung. And a patient like this with stage 1 disease doesn't have any lymph node involvement. Patients with stage 2 lung cancers may have a tumor in their lung and lymph nodes just within the lung themselves, all the way to stage 3 disease, of which I've shown an example here, where you can see the primary tumor in the lung, as well as some lymph nodes in the middle of the chest in this area called the mediastinum here. These are treated somewhat differently. The standard of care here I've kind of put in broad terms. Typically stage 1 cancers are treated with surgery, sometimes with radiation if patients aren't eligible for surgery, all the way to stage 3 disease, which is treated with what we call multimodality therapy, often involving systemic therapy of some form, radiation, and sometimes surgery. And I think the unifying theme here across these different stages of disease is that the goal of treatment here is cure. So we're trying to actually eradicate this cancer or cure patients of their disease. We also talk about the term adjuvant therapy a lot. And this is, I think, a term that's been discussed more and more in lung cancer in recent years. And I remember learning about the term adjuvant therapy as a fellow, so I thought I'd start by defining it. So adjuvant therapy means treatment that's given after curative intent therapy, most commonly after surgery, to decrease the chance of recurrence or to increase the chance of cure. So if you think about surgery, adjuvant therapy is given afterwards. And the way that I explain this to patients is if you think about a surgery, the surgeon tries to take out what they can see based on scans and what they can see intraoperatively. But their concern is that there may be micrometastatic cancer cells that are left behind that we can't see, that may be the seeds of eventual recurrence. And so adjuvant therapy is trying to eradicate those micrometastases. Neoadjuvant therapy is another term you might hear used. And basically it kind of means therapy that's given before the curative intent therapy to, again, improve the chances of cure. Why do we care about adjuvant therapy? Why do we even think about this? Why isn't just treating with surgery or radiation alone? And the answer is these, I think, quite sobering survival statistics for lung cancer as a whole. We've made a lot of advances in lung cancer in recent years, both in terms of treatment in the metastatic setting, as you already heard about, but also advances in early detection, lung cancer screening. But despite all of this, survival for patients with early stage non-small cell lung cancer remains inadequate. And I've shown kind of some of the numbers, which really are, I think, quite sobering. If you look at the 60-month or 5-year survival rates for patients with, again, kind of quote unquote early stage cancers, all the way from stage 1 to stage 3 cancers, you can see that these numbers are nowhere near as good as we need them to be. And I think this really emphasizes the point that better curative approaches are needed for non-small cell lung cancer patients, even in the early stage setting. So, when we think about adjuvant therapy, of course, we want to think about the benefit. What can we give patients to improve the chance of cure? But I think it's also important to talk about the downsides of adjuvant therapy, which are, I think, unique and different from when these treatments are given in the metastatic setting. And this is kind of an oversimplification just to kind of think about that a little bit more. If we look at a group of patients who are treated with, for example, surgery alone, a subset of these patients hopefully are cured with their surgery, but unfortunately another subset will recur. The goal of adjuvant therapy is to add this kind of yellow part to this pie chart here, to add a group of patients that might be cured by their adjuvant therapy. And obviously this is the group of patients that are going to benefit from that treatment. But there's also some patients in this setting, some that were cured before and are already cured. And if they get adjuvant therapy, they're not necessarily going to benefit from that, but there is some risk of downsides, of side effects from that treatment. And then similarly, there's a group of patients that may have recurred, and adjuvant therapy is never perfect and they may still recur. And for both of these groups of patients, there's overtreatment. They may not benefit from that treatment and they stand to to have harm, have downsides, have side effects from treatment, and may not benefit. That's different than in the metastatic setting where we know that the patient needs the treatment and therefore we're more willing and able to kind of take on the side effects of treatment. I think that the risk of harm is important in the adjuvant setting for these reasons. And then lastly, I just wanted to briefly mention some of these terms that we use, in terms of how we measure the chance of cure. So you'll see here in this talk that I'll talk about disease-free survival and overall survival. Disease-free survival is a measure that we use in adjuvant studies to look at the likelihood of recurrence or relapse. It tells us, how likely is this treatment to prevent recurrence or relapse of the cancer. Overall survival, of course, measures whether patients are living longer with that intervention. And we use overall survival as a way to think about whether we're actually curing more patients with that disease. And as you'll see, in some studies, we have disease-free survival, but not yet overall survival information. And I think that's an important factor that we have to weigh when we're kind of thinking about whether or not to adopt an adjuvant therapy. So what is the current, or at least maybe a few years ago, what was the current standard of care for adjuvant therapy in lung cancer? For many years, and this is data actually from back in 2008, almost 14 years ago now, looking at adjuvant chemotherapy. So adjuvant chemotherapy is a standard of care. We consider it for patients with resected non-small cell lung cancers. Again, this is always a patient-by-patient discussion, but broadly, we think about it for patients who have lymph node positive cancers and those whose tumors are greater than 4 centimeters. The kind of recommendation for adjuvant chemotherapy came from a bunch of older studies where we saw, looking at these survival curves, you can see the patients who received chemotherapy after surgery shown in yellow, those who didn't in blue, and you can see basically a slight separation between these curves. The overall kind of benefit of adjuvant chemotherapy is typically thought to be about 5 to 10% absolute benefit, absolute improvement in 5-year survival. So I would say a modest benefit at best. But for years, this has been our only adjuvant standard of care. And I think what we know is that since 2008, when this work came out, we've had many advances in the metastatic setting. And one of the important questions is, what are the roles of some of these newer therapies, targeted therapies specifically for this session, but also immunotherapy, which can benefit patients in the metastatic setting, and how can we use them in early stage disease? So again, this is recapping what we spent the whole morning of this workshop talking about, but we know that now we understand that many non-small cell lung cancers are driven by these particular driver mutations. And for patients with advanced oncogene-driven non-small cell lung cancers, we know that targeted therapies are very effective, and in fact have been shown in many studies to be more effective than chemotherapy, at least as potentially initial therapy for these patients. And so it begs the question, if targeted therapies are so effective for patients with advanced disease, maybe they should have a role as well in the early stage setting, and maybe they can help us cure more patients of their cancer. There has been, a lot of work to be done in this area, but actually I would say until recently, not a lot of progress. Many older studies looked at the adjuvant specifically in EGFR-directed therapies, but many of these older studies were somewhat limited in various ways and did not definitively show us benefit. I will point out that in this talk, like in some of the others, EGFR is the biggest kind of group of oncogene-driven cancers, and is one where we kind of have the most data. And I think one of the questions that we have to ask ourselves going forward is, can we use some of the things that we learn in EGFR positive disease to then think about adjuvant therapies in ALK and others? But there's really very little data in those other oncogenes. We're going to focus on EGFR today. But looking here, this was, I just showed some data from the Radiant trial. The Radiant trial was an older study that took nearly 1,000 patients with resected lung cancers and randomized them to 2 years of adjuvant erlotinib, so a first-generation EGFR inhibitor, or placebo. And this study was done quite a while ago, actually, before we were broadly testing patients for EGFR mutation. So this was actually not a study done in EGFR mutant cancers. It was a study done in lung cancers as a whole. And what we saw is on only a small subset, 161 of these 973 patients actually had EGFR mutant cancers. And among those patients in this study who did have EGFR mutant cancers, where we think the benefit of erlotinib or Tarceva may be the greatest, what we saw was that there was a trend towards an improvement in disease-free survival. Again, that being a measure of kind of the likelihood of relapse with the adjuvant erlotinib. But this was actually, in the grand scheme of the study, a small population, and this was not statistically significant. So this was not a conclusive study. We really couldn't draw the conclusion that adjuvant erlotinib actually helped cure more patients from this study. As you can see here, the overall survival was not different between the two arms. But again, this was a relatively small number of patients. We subsequently had a couple of studies that had a bit of a different study design. And these two studies, one called the IMPACT trial and one called the Adjuvant trial from Japan and China, respectively. Here, we had patients with stage 2 and 3 lung cancers with EGFR mutations who had surgery. And then after surgery, they were randomized by flip of a coin to either the standard of care, which we already talked about, which is chemotherapy, 4 cycles of adjuvant chemotherapy, which we typically would give patients like this, or 2 years of gefitinib, the first generation EGFR inhibitor. So kind of saying, well, can we replace chemotherapy with a targeted therapy? And what we saw in both of these studies is while there was a slight improvement in the disease-free survival, especially early on, you can see these curves kind of separate. When we looked with longer follow-up, these curves seemed to come together over time. And then importantly, in both of these studies, if you looked at how long patients lived, the overall survival, there didn't seem to be a benefit towards the gefitinib arm in these studies over chemotherapy. And so what that told us is that replacing adjuvant chemotherapy with older EGFR inhibitors doesn't seem to cure more patients, doesn't seem to improve their survival. But while those studies were being done, we also had the Flora Trial, which I know you heard about earlier in the session, which showed that in metastatic disease, osimertinib or Tagrisso was a newer EGFR inhibitor that was superior, that was better than drugs like erlotinib and gefitinib, which were used in those studies. So then, of course, came the question, well, what about adjuvant osimertinib? What about adjuvant Tagrisso? And that brings me to, I think, probably the most practice-changing study that I will cover in this talk, which is the Adora Trial, which you may have heard about. The Adora Trial was a study of adjuvant osimertinib or Tagrisso in patients with resected EGFR mutant lung cancer, stage 1B to 3A cancers. In this study, this patient had surgery, and then they could have adjuvant chemotherapy if they were felt to be appropriate for that in discussion with their doctor. And then after completion of surgery and chemotherapy, if they were to get it, then they were randomized to either 3 years of adjuvant Tagrisso or placebo. In this study, the primary endpoint was disease-free survival, so the chance of recurrence of the cancer. And again, overall survival, that number that we use as a measure of the likelihood of that more patients are cured, was a secondary endpoint. And we saw the results of the Adora study first presented at ASCO last year. And what we saw was this is the disease-free survival curve for the study. And you can see in blue here, the patients that received osimertinib or Tagrisso, and in yellow, the patients who received placebo. And at each time point, you can see 12, 24, 36 months, you can see the percentage of patients that were disease-free or relapse-free was much higher in the Tagrisso arm than in the placebo arm. The hazard ratio for disease-free survival in this population was 0.17, which is basically a way of saying that, flipping that over, that there was an 83% reduction in the chance of recurrence with Tagrisso than with placebo. I think, many of us took that and said, wow, that's a big number. That's a big difference in the chances of recurrence. Again, there's a lot of discussion, and certainly in the Q&A, we can talk about some of the pros and cons of the study. Just to show you here, looking at the different stages of cancer included in the study, you can see that the disease-free survival, in each case, there was a difference between these two groups. The magnitude of benefit was greatest in the stage 2 and 3 patients than in the 1B patients, but all of these patients seem to benefit in terms of the chance of recurrence from the adjuvant Tagrisso. I think that real important question in this study is going to be, what about overall survival? Are these 3 years of targeted therapy actually curing more patients? And the answer to that is we don't know yet. This study is still ongoing. Many of these patients are still on treatment. We saw some very early kind of results, but these are not yet statistically significant. There's only 5% data maturity here. And so this is something that we're really going to have to look carefully at going forward. I think also equally important is safety, as we talked about. These are patients that may or may not need this treatment. So what is the impact in terms of side effects and their quality of life? What we saw is that Tagrisso is generally a fairly well-tolerated drug. We certainly know that in the metastatic setting, patients feel better on Tagrisso than some of the older targeted therapies. But when you're talking about taking a drug like this for 3 years, I think obviously it's very important to think about how this impacts patient quality of life. And what we saw in terms of side effects is that Tagrisso can cause some patients to have GI toxicities, diarrhea being the most common, as well as skin toxicities like paronychia, infections around the fingernails, dry skin, itching skin, things like that. The majority of these were mild to moderate. This is the grade 1 and 2 category shown in light blue. And then you can see that dark blue would show patients who had severe symptoms, so grade 3 or 4 symptoms, and there were very few of those here. But I think nevertheless, this is very important. Obviously, when we think about a treatment for 3 years, having even mild to moderate diarrhea ongoing for that period of time can have an important impact on quality of life. And that's part of the discussion, I think, that has to be weighed when considering using this treatment. But taking all of this together, the FDA reviewed this data and actually did say, we think this benefit, although we don't yet have the overall survival results, is meaningful, and approved adjuvant osimertinib in December of 2020. And now I think this is something that's in the guidelines and certainly something that we consider for our patients with resected EGFR mutant cancers. I think that despite the fact that now for EGFR patients, osimertinib is something that we strongly consider, there's many questions that are unanswered, and I've left some of them here, although I'm sure others will come up in the Q&A session. I think one of the ones I already touched on is, are adjuvant therapies improving the chance of cure, or are they just delaying the time to relapse? And how do we weigh those two things? What's the most important endpoint? What is the optimal duration of treatment? Are there some patients in whom chemotherapy is no longer needed? Are there some patients where we can actually delay or de-escalate treatment? How should we think about biomarker testing in early stage cancers? And then importantly, can we extrapolate from Adora to other mutations? What about rarer subsets where we might be difficult to do these kind of adjuvant studies? Can we use the data from a study like Adora to inform what we do there? And again, these are all important questions. And then just lastly, what about neoadjuvant approaches? I've just shown you, one of the studies, the types of studies that are ongoing now. There's a number of different adjuvant studies ongoing, but then there are also some neoadjuvant studies where we're actually taking patients and before surgery, doing biomarker testing, and if they're found to have one of these mutations, giving them the targeted therapy before surgery, with the goal of seeing whether we can improve the response rates to treatment before surgery and being able to study those cancers in the lab, from the specimens we take at the time of surgery to better understand how adjuvant therapies are working. I think these types of studies will really be important going forward as well. And when we think about how we should consider either neoadjuvant or adjuvant therapies. So with that, I'll conclude just to say, really, despite significant advances with the use of targeted therapy for patients with advanced oncogene-driven cancers, targeted therapies aren't yet widely utilized in early stage disease. But in EGFR-positive cancers, the Adora trial did show an improvement in disease-free survival with 3 years of adjuvant Tagrisso, and now is approved for adjuvant use in patients with resected EGFR mutant cancers. But we really need longer follow-up to determine whether adjuvant osimertinib cures more patients or delays the time of relapse. And then, of course, we really need to learn more about the role of adjuvant targeted therapies in other oncogene-driven cancers.